All right, so thank you to the SMSNA and Dr. Burney for the opportunity to present today. So I'm a pediatric urologist at the University of Wisconsin, so we're really kind of changing gears from the previous talks, but I'm very excited to speak with you about one of my passions, which is transitional urology. I have no conflicts of interest for this talk. So in terms of objectives today, we're going to talk about challenges, assessment, and management considerations for transitional urology patients. And just to be clear, in case you don't know what I mean by transitional urology, this really refers to the adolescent or young adult patient with a congenital urologic condition who's making that transition from pediatric to adult care. So patients with congenital urologic diseases are living well into adulthood with advances in medical care. So there's many diseases out there that were traditionally thought of as pediatric that now affect adult patients and then may impact their sexual functioning. So this would include spina bifida, bladder exstrophy and epispadias, and genital anomalies and intersex conditions. So in terms of sexuality challenges for spina bifida patients, spina bifida affects the lower spinal cord, and so the nerves that innervate the sexual organs are affected. So these patients will often have altered or absent genital sensation, and then in males, erectile dysfunction. Urinary and fecal incontinence during sexual activity in these patients is a huge problem. So a recent study published in Urology estimated that urinary incontinence during sexual activity in these patients is around 70% and fecal incontinence about 45%. These patients are at a high risk for sexual abuse. So 20% of adults with spina bifida have reported experiencing sexual assault. Their sexual education is typically poor. Due to their disability, unfortunately, many of these patients are not thought of by their doctors as sexual beings. And then finally, pelvic organ prolapse is a problem for females due to the pelvic floor tone being decreased. For exstrophy and epispadias, challenges again in males and females. Males can have difficulty with penetration due to decreased penile length. Dorsal chordee is present in about 49% of adult patients. Erectile dysfunction and diminished sensation of the penis can occur due to their prior surgeries, and their bladder necks are abnormal, so they often have abnormal seminal emission and ejaculation. For females, vaginal stenosis and dyspareunia are due to prior surgical reconstruction. They have abnormal pelvic floor musculature. They have a wide apart pubic symphysis, and so that can cause uterine prolapse. And then again, impaired clitoral sensation with resulting anorgasmia can occur from prior surgeries. And then because of the abnormal bladder neck, both male and female patients can struggle with incontinence during sexual activity. Sexuality challenges in congenital genital differences, again, that can affect both males and females. So in males, we're thinking about hypospadias, intersex conditions, and then in females, intersex conditions or cloaca. So their adult sexuality concerns are typically related to complications from prior surgery. So for males, that's chordee, erectile or ejaculatory dysfunction, and then in females, vaginal stenosis or dyspareunia. These patients are often very concerned as well about how their genitals may look different from others or how they experience different sensation. So I want to spend a little bit of time discussing with you what I do in my transitional urology clinic to evaluate sexual functioning in these patients. So patients in my clinic are typically 18 or older, and I actually do send a letter to all of my patients beforehand to notify them that a discussion of sex is kind of a standard part of this clinic so they can be prepared. The first thing that I do is give questionnaires to all my patients, which really helps kind of start that dialogue. I really like questionnaires that are short. So for males, I typically use the SHIM, which all of you are very familiar with. And then for females, I use this FSFI short form questionnaire, which has 6 items, and they addressed interest in sex, arousal, lubrication, orgasm, pain, and then overall sexual satisfaction. So in terms of history, all of my patients really get a detailed history of their bladder and bowel function, since optimizing this can really improve their sexual functioning, which we really saw in the last talk that was just given. So understanding their GU surgical history is really important to understand the patient's anatomy and any challenges related to it. I always discuss legal guardianship in all my patients with disabilities because this really helps me understand, can they consent to sexual activity? Is this going to be relevant for them? I take a social history to really understand their level of functioning. So do they live independently? Do they work? What's their potential for relationships? And then finally, everybody gets a full sexual and fertility history at that first visit. And actually, for most of my patients, I would say this is the first time a doctor has ever really talked with them about sex. One of the things that I find helpful is to assume patients masturbate, even if they haven't had sexual contact with another person. So they usually do have some sense of their own sexual abilities. And then if they haven't had sexual contact with another person, I ask about what's their goals for the future. Do they want to have relationships? Do they want to have children? And I think that's important so that we can allow those goals to happen. So what to do about parents? So I think for my adult colleagues, I think this can be really intimidating. It's a challenge. What do I do about these parents in the room? How do I deal with it? So my approach, if this is the first time that you're talking about sex with one of these patients, I bring up the discussion with the parents in the room. Many of my patients have disabilities. That caregiver and patient relationship is very strong, and caregivers want to be involved with these discussions. So once I bring it up, usually the patient and the caregiver are pretty receptive to the discussion, and then I ask the patient, do they want their parents out of the room? And my experience has been for most who aren't sexually active yet, they want their parents to stay, actually. For any families that are sort of reluctant to discuss sexual activity, I think that's where you can take advantage of your longitudinal relationship with the patient. So keep bringing it up. Set a timeline up for when it can be time to have those confidential discussions. This golden ticket is actually an idea that I got from Dr. Gunter de Win at Antwerp University at a recent conference, and I really loved it, and I started implementing it in my clinic. So basically, these patients often don't come prepared with questions, and so he offers them a golden ticket where they can basically schedule a visit at any point where they can ask any of their sexual health related questions. So I started doing this for my patients. And then finally, if your patient is under 18, just make sure you know the laws in your state regarding adolescent rights to confidential medical care. So management considerations. Sexual counseling is really critical for these patients, a huge part of my practice. Up to 48% of women with spina bifida are sexually active by age 23, but as few as 5% have ever talked with a doctor about this. So we really need to be at the front lines for talking about safe sex and relationships. The majority of spina bifida patients actually report they want their doctor to be the #1 resource of sex education for them. So things that I always try and discuss, safe sex practices, relationship safety, STI prevention, and pregnancy prevention. So some important points for spina bifida patients specifically, you really have to avoid latex condoms because they have latex sensitivity. And then there is a false positive pregnancy test risk in patients with a history of a bladder augmentation. About 50 to 75% will test positive, so just something that they should know about. Referrals, I make a lot of referrals from my clinic. I think OT can be really helpful for gaining independence. I refer often to OBGYN for patients that aren't on birth control and really haven't discussed that yet. We actually just hired a sex therapist at the University of Wisconsin. I think this is going to be a beneficial resource for my patients. I also think that it's kind of important for doctors to know about some of the sex aids that are out there that are sort of needed for these patients with disabilities. I just learned about this intimate rider chair, so that's an important piece of things. I wish we had more time to talk about treatment options. Just wanted to bring up a few points that might be of interest. For erectile dysfunction in the neurogenic bladder patient, typically Viagra is very successful, but there may be some patients that need a prosthesis. There's been a lot of historic concerns about increase for implant infection and erosion risk if the patient's cath, but really modern series are showing really similar satisfaction rates to the general population and just a slightly overall higher complication rate. And then finally, the Tomax procedure, that's actually something that I'm working on with our plastic surgeons at UW to be able to offer to my patients. And it's where the ilioinguinal nerve is transferred to the dorsal penile nerve. And so because the ilioinguinal nerve originates at L1, any patient with a lesion below that is a candidate for this. And case series have shown about an 80% success rate. The risks are a loss of reflex erections in bilateral procedures since the dorsal penile nerve is involved in the reflex erection arc. So overall, I think care for transitional urology patients, it can be challenging, but I find it really rewarding. I think urologists should be at the front lines of sex education and counseling. I like to use standardized questionnaires, use parents as your allies to get the discussion going, and then just consider that they can be complex in their treatment and surgical management. So thank you. I'd love to collaborate with any of my adult colleagues, so as a pediatric urologist. Thank you so much.